Hello. I'm sorry. I'm going to do a mental health series. I am a retired clinical pharmacist and I specialized in psychiatric pharmacy. So I worked 20 years with people with psychiatric disorders. And the first psychiatric disorder I want to talk about is schizophrenia. Schizophrenia is scary to a lot of people because they don't understand it, but it is not something you should be afraid of. Most people with schizophrenia are not dangerous. And I want to say, first and foremost, I do not like the word crazy. I do not like people calling people with schizophrenia or other mental illnesses crazy. It's very offensive and it's just inaccurate. Schizophrenia is a mental illness, it is a brain disease. People with schizophrenia have an excessive amount of a neurotransmitter called dopamine in the brain. They have an excessive amount of neurotransmitter dopamine in the frontal cortex that can cause negative symptoms of schizophrenia, and I'll talk about that, and in other parts of the brain that can cause positive symptoms of schizophrenia. Now, to be diagnosed with schizophrenia, you have to have two of five symptoms, and those symptoms are hallucinations, delusions, disorganized speech, disorganized behavior or catatonic behavior, and then negative symptoms. So let's go over each symptom. Let's start with delusions. Delusions are, you probably know, are false beliefs. So someone with schizophrenia may think that they're being poisoned. They may think that someone is, I'm sorry, I'm hot. I'm just hot. I'm sorry, I'm hot. They may think that someone is poisoning their food. They may think that a family member is out to get them, hate them. They may have the false belief that, I don't know. Actually, this is my second time taping this. I do not know what happened to my first footage. But my first footage, I gave the example of, like, say they may think they're the president. And then I thought about it and I said, well, wait a minute. I guess it's possible, but that would be considered a grandiose delusion. And most people who have grandiose delusions have bipolar disorder, particularly bipolar 1 disorder, okay? So people with schizophrenia tend not to have grandiose delusions, but they do have delusions like their food is being poisoned, or people are talking about them, that something called thought broadcasting, like their thoughts are being broadcasted over the news. People can read their minds, or read their minds, know what they're thinking. They may think that, anyway, they're false beliefs, and they're fixed false beliefs. So that's delusions. And most people with schizophrenia have some kind of delusions. Like I had a patient who thought she was pregnant. She wasn't pregnant, but she thought she was pregnant. Hallucinations. Hallucinations pretty much affect all the senses, if you will. Like the most common is auditory hallucinations. So you may hear people that are not there. Like as I'm speaking to you, someone with schizophrenia will hear someone speaking to them, but they're not there. And they can hear more than one person. It can be running commentary where the person, the auditory hallucination is making commentary about the person, what they're doing, their behavior, their movements. I mean, it can be really, that's considered very severe. If you're hearing more than one voice and they're making commentary about what you're doing, that's considered a very severe type of hallucination, and it can be very, very damaging to the person. Now, some people have hallucinations that aren't as bothersome. Some people have hallucinations what makes them laugh, okay? Some people have hallucinations, obviously, that's very disturbing and detrimental to their self-esteem and their ego. The other type of hallucination would be olfactory hallucination, is where you smell things that aren't there. You may smell very foul odors that other people can't smell. That's called an olfactory hallucination. Another type of hallucination is called tactile hallucination. Tactile hallucination would be like you feel things on your skin that aren't there. Maybe you feel bugs on your skin that aren't there. And of course, that's very disturbing. When I think about it, most people who have tactile hallucinations are alcoholics who are in DTs, whatever, and they say that they feel things on their skin. But there are patients with schizophrenia who do have tactile hallucinations. Most people, when they think of people with schizophrenia, they only think of hearing voices. But not only can they hear voices, they can see people that aren't there. I don't know if you've ever seen the movie John Nash. He was a famous mathematician, very brilliant guy, genius, and he actually did have visual hallucinations. So, yeah, I do know some people who have visual hallucinations. Again, I've had patients tell me they've had smell things that aren't there. I had one patient said she smelled flowers, but of course, there were no flowers there. And again, the tactile hallucinations. So we talked about delusions, hallucinations. Now let's talk about disorganized speech. Disorganized speech is speech that basically just doesn't make sense. It doesn't come to full circle. It's not able to be comprehended. A lot of people with disorganized speech, they do unusual things, like there's something called echolalia. Echolalia is where a patient will echo, if you will, what something someone else is saying, or parrot. These are very sick people. What I'm describing now is for someone who's very sick, someone who most likely is institutionalized. And unfortunately, now I'm jumping subjects a little because I talk about institutionalized. You probably know they have closed a lot of the psychiatric hospitals. So a lot of people who are severely ill are now homeless. So not all homeless people are drug addicts. Some homeless people, and many you may know, have schizophrenia. You can tell if someone's, unkept and they're talking to themselves, they're schizophrenic, and they were put out of the hospital. They closed a lot of the psychiatric hospitals where I live. I live in Maryland. They used to have many psychiatric hospitals for people with severe mental illness, but they closed them. And now these people, they are on the street and they have nowhere to go. They have no family, or the family doesn't want them. But that's another story. So, yeah, now I lost my train of thought because that's something that pains me, that these people are out on the street. So we were talking about disorganized speech. Yeah, so we talked about echolalia. Another thing is something called poverty of speech. Poverty of speech is where basically a patient's non-communicative. They may give you yes or no answers. They say very few words. Maybe, yeah. Uh-huh. I think so. It's just, and they don't carry on a conversation. You have to carry on the conversation for the person. You have to draw them out in order to get a response. Okay, that would be part of disorganized speech, and also that would be a negative symptom too. Yeah. So, but the main trademark characteristic of disorganized speech is that it just doesn't make sense. Like they talked about something that they used to call it word salad, where they just different words doesn't make sense. They're using different words, but it's not a sentence. It's just gibberish. There we go. It's gibberish, and it's very sad. And again, these people like that are extremely ill. Then I talk about disorganized behavior. Disorganized behavior. The most common thing I see are people losing things. They constantly lose their keys. They constantly lose their cell phone. They're just constantly losing things, and they don't know where they put things. That would be disorganized behavior. Another thing that I talked about, if I didn't talk about it, but they link it with disorganized behavior, and it used to be in a classification by itself, but in the new DSM-5, which is where they diagnose psychiatric illnesses, they classify something called catatonia with disorganized behavior. Catatonia is where a person, they may sit in a specific position for hours on end. They used to call it a waxy flexibility. They could have their body twisted in a position, like this. And they'll just sit like that for hours on end. And the doctor will come and try to move their limbs, and they won't move. So that's catatonia. Okay, so we talked about hallucinations, we talked about delusions, we talked about disorganized speech, we talked about disorganized behavior and catatonia. Now, and those are connected together. So the fifth symptom of schizophrenia would be negative symptoms. So in order to be diagnosed with schizophrenia, you have to have two. So if you have delusions and hallucinations, you can be diagnosed with schizophrenia. But they have to rule out other things, because a person with bipolar disorder can also have delusion and hallucination. So it's not so cut and dry as they make it sound. Negative symptoms of schizophrenia. Negative symptoms is very tragic, just like positive symptoms. I want to say one more thing about positive symptoms that they really don't mention in the DSM-4, but is definitely prevalent in a lot of patients. Some of my patients are combative. Okay, they're just combative. You know, they want to fight staff, they want to fight people, and that's just it was considered a positive symptom of schizophrenia. Now, negative symptoms of schizophrenia are things like we talked about, poverty of speech, where a person really doesn't say anything. They give you like yes and no answers. They're non-communicative. You have to draw them out. You have to carry on the conversation. That's a negative symptom of schizophrenia. Another negative symptom of schizophrenia would be poor grooming and hygiene. In fact, I think that's the major one. Well, poverty of speech is really big too, but poor grooming and hygiene, I'm sure most people have seen that in people with schizophrenia. So poor grooming hygiene basically just means that a person doesn't want to take a bath, they don't want to brush their teeth, they don't want to wash their hair, they don't want to comb their hair, they don't want to wash their clothes, they may throw their dirty clothes on the floor, put them back on the next day, put their dirty underwear on the next day. They have a very, very foul body odor. I'm sure you've come across people with schizophrenia like that. So it's not that they're lazy, it's just part of their disease. It's a negative symptom of schizophrenia. Another negative symptom of schizophrenia is social withdrawal. So the person, even though they may have been sociable before, once they get this disease, they just want to be by themselves. They're isolated. So that's another negative symptom of schizophrenia. Another one is flat affect. Flat affect is where they show no emotion. You know, their face is just, it's like blank. And you have to see it to really understand it. I can't really imitate that, but it's very sad. And another thing about, yeah, I can't even describe what it looks like. It's just, they're blank. They're blank. There's no, thank you, Jesus. There's no expression in their eyes. Their eyes are just blank. There's no expression in their eyes. And another thing that some people with schizophrenia do, which is a negative symptom, is that they may, they have inappropriate affect. Like you could tell them their mother died and they start laughing, you know, and it's not that they think it's funny, it's the disease. You know, it causes them to laugh at something that's very sad. Or you could tell them something that's funny and they may start crying, or they may start yelling or something like that. That's a negative symptom of schizophrenia. Negative symptoms of schizophrenia are harder to treat than positive symptoms of schizophrenia. Negative symptoms of schizophrenia, okay, again, this is my second take. I do not know what happened to my first footage. I mentioned in my first footage, my mouth was getting dry. I have something called undifferentiated connective tissue disease, and it causes me to have a dry mouth, and I'm running out of water, so I'm going to try to hurry up. So anyway, yeah. So negative symptoms of schizophrenia is caused by an excessive amount of dopamine in the frontal cortex, or in the front of your brain, okay? And positive symptoms of schizophrenia is caused by an excessive amount of dopamine in other parts of the brain. Negative symptoms, as I said, is very, very hard to treat. The traditional antipsychotics that they used to use and that they rarely use nowadays, like Haldol, Prolixin, those are the main ones, and those are high potency neuroleptics. They are very powerful in treating positive symptoms of schizophrenia. They have a very high affinity for dopamine receptors. Again, remember, that in schizophrenia you have too much dopamine in the brain. So this drug binds to dopamine receptors and decreases the amount of dopamine in the brain, so it will decrease the positive symptoms in schizophrenia. But the older drugs like Haldol and Prolixin, they don't work in the frontal cortex. So they made a newer class of drugs that they called atypical antipsychotics, and that would be your clozapine, that would be olanzapine, risperidone, ziprasidone, Abilify. These are the newer drugs, and they work for negative symptoms of schizophrenia. And how they work is they decrease the amount of dopamine in the frontal cortex, and also they work on the serotonin receptor as well, which is thought to be responsible for negative symptoms of schizophrenia. To be honest, in my practice, it's very difficult to treat negative symptoms of schizophrenia. I've never really seen them go away completely. I have seen people get improvement with medication and with therapy, group therapy, one-on-one therapy with a therapist, but it's very hard to treat. And even positive symptoms are very hard to treat. To be honest, none of my patients, I've never had a patient said the voices have completely gone away. Usually what they'll tell me is, well, I can ignore them now, or they're more quiet. Okay, that's what they'll tell me, but I've never had a patient tell me that the voices have completely gone away. So I wouldn't say that any of these drugs are obviously a cure for schizophrenia or completely get rid of all of the symptoms, but they can attenuate the symptoms. Now let's talk about side effects. One of the reasons why, besides the fact that the older drugs do not treat or help negative symptoms of schizophrenia, which most people with schizophrenia have, is that they cause something called extrapyramidal side effects, or EPS, you may know it as. They also cause a devastating illness or side effect called tardive dyskinesia. Extrapyramidal side effects would be akathisia, where you just can't sit still. You just feel like maybe you're pacing back and forth. Another extrapyramidal side effect, the most common one, would probably be stiffness, as you may know it. Like the doctor may test your arms to see if your arms are stiff. And they call it cogwheeling, if they can feel like your muscles moving in your arm and they stiffen up. Okay, so that would be a type of dystonia, stiffness. That's a type of extrapyramidal side effect. Another type of extrapyramidal side effect would be Parkinsonianism. They call it pseudo-Parkinsonianism because it mocks, if you will, Parkinson's disease, but the patient doesn't have Parkinson's disease. It's a side effect from neuroleptic treatment or antipsychotic treatment. And Parkinson's disease is thought to be caused by not enough dopamine in the brain. So if you give someone a neuroleptic and you're depleting their dopamine in the brain, then they can start to look like they have Parkinson's disease. They can start drooling, they may have decreased arm swing, they may have a shuffling gait. And so in circumstances like that, what you want to do is decrease the drug, obviously, or change it to another drug. If they're on a traditional antipsychotic like Haldol, you want to put them on a atypical antipsychotic like risperidone or olanzapine to prevent that from happening. Another thing, what a lot of psychiatrists will do is when a person starts a neuroleptic medication, they will put them, particularly Haldol or Prolixin or risperidone. I'll talk about risperidone in a minute, which happens to be one of my favorite drugs in the treatment of schizophrenia, is they will put them on a drug called cogentin. And the reason why they put them on cogentin is because it will prevent extrapyramidal side effects. So I want to let you know, though, you really should only be on cogentin for 3 months maximum. And then your doctor is supposed to, I'm getting tired. So your doctor is supposed to try to wean you off of cogentin. And if extrapyramidal side effects emerge, like if you start to get stiff or you get akathisia or some Parkinsonian type symptoms, then your doctor will put you on it. But it's not meant to be lifelong treatment. And another thing is if these extrapyramidal side effects are manifesting when you are taken off of cogentin, your doctor really needs to make the decision, well, should I put this person on another drug so they don't have to deal with these side effects? You have to always weigh the risk versus benefit. So if the drug is really helping your schizophrenia and it's decreasing your symptoms, but unfortunately it's causing some Parkinson type symptoms or stiffness, then the doctor may say, well, I'll just keep the patient on cogentin, or he may lower the dose. Uh, but the best option, unless it's really helping you, is to switch to another drug to see if you can tolerate that drug better. Always tell your doctor if you're having side effects from a drug, because he can always adjust the dose. He can always decrease the dose. He can always change the medication to another medication. So please always tell your doctor. Now, a lot of people, in fact, most of my patients who have schizophrenia, they don't think they're sick. They don't think there's anything wrong with them. So they stop taking their medications. They're not medication compliant. And so what happens is, obviously, their symptoms aren't getting better. So what we tend to do, people like that, we put them on long-acting antipsychotic intramuscular injection, like Haldol D, Prolixin D. Now they have the newer atypical agents come in long-acting formulations. Risperidone, there's a long-acting formulation. Caliperidone, which is a metabolite of risperidone, there's a long-acting formulation. They even have a long-acting formulation for Abilify, which is also FDA approved in the treatment of bipolar 1 disorder. And bipolar 1 disorder is the next disorder I will talk about in this series. But anyway, yeah, so that's what they do. And the good thing about paliperidone long-acting injection is that I'm out of water. And I don't, anyway, paliperidone long-acting injection, the patient only has to get an injection every 3 months. So a lot of my patients really like that. I mean, imagine getting an injection every 3 months as opposed to once a month like you have to do with Haldol, or every 3 weeks like you have to do with Prolixin and risperidone. I think Prolixin may be every 2 weeks. I can't remember. I don't have many patients on Prolixin anymore. Yeah, I still have a lot of patients on Haldol D. It's cheap and it helps a lot of people, but you are at greater risk for extrapyramidal side effects, and you are at greater risk for tardive dyskinesia. Did I mention tardive dyskinesia? I don't think I went into detail about what it is. Tardive dyskinesia is a movement disorder. It's a movement disorder that can happen to someone who's been on long-term. I'm so hot in this room. I'm sorry. I am so hot in this room. I know it's wintertime, but I don't know. Maybe it's my connective tissue disease that makes me. Sometimes I just get really clammy and flushed. And that's how I'm feeling now. But anyway, yeah, it's a movement disorder. Tardive dyskinesia is a movement disorder that usually occurs in people who have been on long-term antipsychotic therapy, greater than 2 years, usually 2 to 5 years, and it's more prevalent in men. It can happen in women too. Most of the people I see with tardive dyskinesia, they have been on it for at least 5 years, and the longer you're on it, the more severe. So if you get tardive dyskinesia, the best thing to do is to switch you to an atypical antipsychotic. In fact, that's why they made atypical antipsychotics, so people won't get tardive dyskinesia, so people won't get extrapyramidal side effects. Now, the newer antipsychotics do block, they are D2 blockers or dopamine blockers. However, they're not as strong dopamine blockers as a Haldol or Prolixin. So you're less likely to get tardive dyskinesia or extrapyramidal side effects or EPS with the newer agents. What else? So some of the movements, the abnormal movements you will see with tardive dyskinesia, like they call it bomb, if you will, and basically what happens is you'll see a patient do that. I see a lot of elderly people do that. They may even stick their tongue out. They tap their feet. They may tap their hands. When they walk, it's hard to describe. They may walk bent over in a twisted motion. They just have these weird movements. They have these weird movements, and it's tardive dyskinesia. It's very painful to watch someone who has severe tardive dyskinesia. Fortunately, it's not reversible. There has been some studies that showed in the past that high dose vitamin E can help decrease symptoms of tardive dyskinesia. So in my practice, I would often recommend to psychiatrists, well, give the patient 400 milligrams of vitamin E 3 times a day or 4 times a day to help with the tardive dyskinesia. Another train of thought, there were some studies that showed if you switch the patient to clozapine, clozapine helps with tardive dyskinesia. But clozapine is a drug that a lot of patients don't like because you have to get blood draws because of the concern of agranulocytosis, where your white blood cell count drops so low that you are prone to get all kinds of infections. So people who are on clozapine, I have to register them. When I was working as a pharmacist, I would have to register them with whatever clozapine company, like say if it was a generic company, whatever generic company they were getting the medication from, I would have to register the patient with that, let them know, hey, this patient's on clozapine, and I would have to call in with their white blood cell count, and ANC was as often as it was checked. Initially, it's done every week, then it may be done bi-weekly, and then maybe once a month. So they have extended it if your white blood cell count and ANC, which is absolute neutrophil count, if it's stable, then you can have your blood cell, you can have your blood drawn less. So yeah, that's clozapine, but it's helped a lot of people, but that's the only turn off about it. And but even with Haldol, I mean, you can get drug levels with Haldol. Like I've had a patient who had really excessive drooling and tremor, and I said, get a Haldol level, and their Haldol level was too high. So they decreased the dose, and actually I was a proponent of having them switch it to atypical antipsychotic because they're safer as far as that goes. Now, I talked about the side effects of traditional antipsychotics, tardive dyskinesia and extrapyramidal side effects, which are the two biggies. Well, with the newer drugs like olanzapine, Seroquel, Abilify, and risperidone, and maybe not as much with risperidone or Abilify, is weight gain. And that's because these drugs cause carbohydrate craving. So people are eating more food so they can gain massive amount of weight on these drugs, which can lead to diabetes, which can also lead to cardiovascular disease. So we often say in my profession, okay, so you're trading movement disorders and extrapyramidal side effects for a person potentially getting diabetes or cardiovascular disease. So what are you going to do? As I said, most people have negative side effects of schizophrenia, and the older drugs just don't treat them very well. But they've figured out or discovered what part of the brain causes the negative side effects of schizophrenia, and they've designed drugs to trigger that part of the brain to help decrease those negative side effects. Yeah, negative symptoms, I'm sorry, I'm tired. Negative symptoms of schizophrenia, like we talked about poor grooming and hygiene, we talked about poverty of speech, we talked about social withdrawal, flat affect, or just some of the symptoms of negative, or some of the negative symptoms of schizophrenia. So they're positive symptoms, they're negative symptoms. The positive symptoms, you have your hallucinations, delusions, you have disorganized speech, combative behavior in some patients. Negative symptoms, you have social withdrawal, you have poor grooming and hygiene, you have flat affect, you have a patient possibly being non-communicative, okay? And I want to say one thing about negative symptoms. A person who has a preponderance, or mainly negative symptoms, they have a poorer outcome than patients with predominantly positive symptoms of schizophrenia. We're really not sure why. Usually, a person with a lot of negative symptoms, usually schizophrenia runs in the family. Maybe a parent has it, or a brother, or sister, or grandparent has it. Another thing that leads to a poor prognosis if the schizophrenia onset is insidious. So if it just, sort of creeps along and slowly, and then after, the person changes, and then after a while they get the diagnosis of schizophrenia. But if someone just, immediately becomes psychotic and starts hallucinating and having delusions, actually that's a better prognosis. That's a better prognosis than for a more insidious onset of the disease. I can't think of anything else to say. Talked about medications. Talked about cogentin. Talked about drug levels. I talked about criteria for schizophrenia, that you have to have 2 out of 5 symptoms, and I said those 5 symptoms are delusions, hallucinations, disorganized speech, disorganized behavior, catatonic behavior, and negative symptoms. And it's not cut and dry because you can have someone with bipolar disorder who has delusions and hallucinations. So you're going to say they're schizophrenic? No. So it's really not that cut and dry. So you really have to look at the overall picture of the person. What kind of delusions are they having? Do they think they're the president? Do they think they're a genius? You have there are other things. I mean, you just have to look at the whole picture, because I'm going to talk about bipolar 1 disorder next. And bipolar 1 disorder is a whole other beast in itself, if you will. It's a whole other, I don't need to call it a beast, but it's a whole other disease in itself that's just as disturbing. So yeah, that's all I have to say. I can't think of anything else to say. So if you have schizophrenia, or if you have family member with schizophrenia, please encourage them to take their medications, because it will help decrease their symptoms and also help prevent them from being admitted into the hospital. People who do not take their medications, they get readmitted frequently. So it's best to take your medications. Also, it's good if you have some type of therapy, especially if you have negative symptoms or even positive symptoms, just to talk it through with your therapist. Group therapy, so you can talk to your peers, people who are going through the same thing. So just be encouraged that there is help out there. You're not crazy. It's a brain disease. It's no different than someone who has, say, epilepsy, or someone who has Parkinson's disease or cancer. It is a brain disease. There are definitely changes in the brain with people who have schizophrenia. We've seen the brains of people who are deceased. We've seen their brains, and they look very different than a healthy individual. Okay, God bless you. Take care. Happy New Year. Bye.